An established office visit was billed as 99214. Then the payer reviewed it and adjusted the service to 99213. The reason? The documentation supports low, not moderate, medical decision-making. So what happens next? Do we defend the billed level, correct the claim, or accept the result and learn from it? The answer does not depend on how strongly we disagree. It depends on what the record can prove. For now, the decision stays pending. This is a fictional, privacy-safe training scenario. It is not payer-specific advice, and the available routes and deadlines vary. Start by reading the reason exactly. Our notice says, level of service not supported. The reviewer concluded that the record supports low-complexity MDM and adjusted 99214 to 99213. That is an EM coding level dispute. It is not the same as insufficient documentation, no documentation, medical necessity, or a clerical error. Those issues may require different evidence and a different response. If you misidentify the problem, even a well-written reply can answer the wrong question. Use a 5-step review. Read the reason. Rebuild the encounter from the contemporaneous record. Test the coding logic, medical necessity story, and any contradictions. Choose the route allowed by the actual payer notice and policy. Then document a rationale another reviewer can follow. The order matters. A route chosen before the reconstruction can turn a correct instinct into the wrong submission. Notice what is not on that list. Adding facts after the encounter. Arguing from diagnosis names alone. Or changing the claim simply because a payer reached a different result. First, we rebuild. The response comes later. Separate 3 things: the submitted claim, the clinical note, and the challenge reason. The claim identifies an established office visit reported as 99214. The note documents stable hypertension and dyslipidemia. The clinician continues management, orders a lipid panel and a basic metabolic panel for follow-up, and addresses a pharmacy closure that is interrupting access to the patient's prescribed treatment. ARB samples are provided as a temporary bridge while the patient finds a new pharmacy. No total time is documented, so we cannot switch to time now. MDM is the available selection path, and the challenge is specific. The payer's review says that MDM is low. Now we can test that conclusion against the record, without adding anything to it. Begin with problems. The question is not, which diagnoses appear somewhere in the chart? It is, which problems were addressed during this encounter? Hypertension and dyslipidemia are both documented in the assessment and plan. Their status is stable, and the plan connects them to continued management and follow-up testing. For this case, 2 stable chronic illnesses support moderate problems. Stable does not automatically mean low, and a diagnosis does not count merely because it sits on a list. The record must connect the condition to today's evaluation or management. Here, it does. That directly tests the payer reviewer's low complexity conclusion instead of arguing from the code alone. Problems, moderate. Next is data, and this is where a defensible review shows restraint. The clinician ordered a lipid panel and a basic metabolic panel. Those are 2 unique test orders documented in the plan. We do not count future results that have not been reviewed. We do not invent an outside note, an independent interpretation, or a discussion that did not occur. And we do not count the same item twice. For this encounter, the documented orders support low data. There is no reason to stretch that conclusion. One element may remain low while the overall MDM reaches another level. A disciplined defense does not force every column upward. It reports each element exactly where the record supports it. Data, low. Now test risk. The record contains two supports for moderate risk, and a defensible response needs both. First, the patient's pharmacy has closed. That documented social factor significantly limits access to the prescribed treatment. Second, the clinician responds by providing ARB samples as a temporary bridge. That is prescription drug management. The two facts are connected, but they are not interchangeable. The pharmacy closure explains the access limitation. The samples document the clinician's prescription management response. No medication changes does not erase that work. The clinician made a treatment decision to maintain the prescribed therapy and prevent an interruption. A rationale that mentions only the samples loses part of the clinical story. A rationale that mentions only the pharmacy closure loses the management response. Risk, moderate. Now align the three MDM elements. Problems are moderate. Data are low. Risk is moderate. Problems and risk meet the 2 of 3 requirement, so the overall MDM is moderate. But before we choose a response, test whether the documented work and the reported service tell one coherent story. CMS describes medical necessity as a primary payment consideration for Medicare. Other payers may apply their own rules. This is not a fourth MDM column. It is a check against reporting a higher service when a lower one better reflects the work. Here, the conditions addressed, follow-up testing, pharmacy access barrier, and treatment bridge connect. The note's routine tone does not contradict the documented management. Its length does not determine the level either. The evidence is coherent. The route is still the next decision. Now we can reveal the result. For this established patient encounter, Moderate MDM supports 99214. The submitted claim matches the contemporaneous record, and the record supports the reported level. So, the appropriate general path is to challenge the adverse determination through the review or appeal process identified in the actual notice. That does not guarantee a favorable outcome. It means the response is supportable. The other routes remain important. If the claim contains a correctable submission or coding error, follow the payer's correction or reopening instructions when applicable. If the record does not support the billed level, do not defend it by adding facts. Correct the claim when the rules and circumstances allow, or accept the determination and use the finding to improve the process. For this record, the defensible route is to challenge the adjustment with the supporting documentation and a concise rationale. Here is the rationale another reviewer should be able to reproduce. This is an established office visit selected by MDM. Total time was not documented and was not used. 2 stable chronic illnesses, hypertension and dyslipidemia, were addressed, supporting moderate problems. A lipid panel and basic metabolic panel were ordered, supporting low data. Risk is moderate for 2 documented reasons. The pharmacy closure significantly limited access to the prescribed treatment, and providing the ARB samples constituted prescription drug management. With 2 of the 3 MDM elements at moderate, the record supports Moderate MDM and 99214. That is the core of the response: concise, traceable, and limited to facts already in the record. Attach the required source documentation and follow the notice's submission instructions. The rationale is not a substitute for either one. I can make this review faster and more consistent, but only if its role is clear. It can organize the note, submitted claim, challenge reason, and applicable policy. It can reconstruct problems, data, and risk, expose contradictions, preserve an evidence trail, and draft a rationale for review. It cannot prove that the payer used AI. It cannot choose a payer-specific route without the actual notice and current instructions. And it cannot turn missing documentation into support that never existed. The professional still verifies the evidence, resolves ambiguity, checks the governing rules, selects the response, and owns the final sign-off. That checkpoint also catches a confident draft that answers the wrong denial reason or relies on an outdated policy. AI organizes the defense stack. Human judgment decides what the stack actually supports. Now remove both risk supports from the record. There is no documented pharmacy access barrier and no prescription drug management through the ARB sample bridge. Leave everything else unchanged. Problems remain moderate because 2 stable chronic illnesses were addressed. Data remain low because 2 unique tests were ordered, but risk is now low. Only one of the 3 elements reaches moderate, so the overall MDM falls to low. For this established patient encounter, that supports 99213, not 99214. In the revised record, defending 99214 would be wrong. The fact that it was billed does not create support. Do not backfill the chart. Follow the applicable correction process when available, or accept the result and use it for education and improvement. Let's lock in the review method. Read the exact reason. Rebuild the encounter from the source record. Test problems, data, risk, medical necessity, and contradictions. Choose the route allowed by the payer's current instructions. Then write a rationale another reviewer can trace. Defend the level when the record supports it. Correct it when it does not. That standard protects both sides of the review. Appropriate defense when the evidence is present, and appropriate correction when it is not. Use the EM Payer Review Decision Worksheet linked below to work through your next training case or internal review. And if your team handles this process at volume, Brightcore's Audit Sentinel is designed to organize documentation comparison, surface gaps, and produce structured findings for human review. The worksheet and the method remain useful with or without a product. Which part is hardest in your denial reviews? Finding the reason, rebuilding MDM, testing medical necessity, or writing the rationale? Tell us in the comments. Choose the next lesson on screen and subscribe to Brightcore AI for more clear, defensible medical coding education.